Well, good evening, everybody. Welcome to the virtual community health forum on cardiac care rather. I'm Christian Hill from the St. Joseph Hospital and Rebel Memorial Hospital Communications Department here in Northern California. Welcome to tonight's forum. It's our distinct pleasure to have you here tonight for the first of our virtual community health forums. Many of you joining tonight have come to our in-person pre-COVID community forums that we've done over the last few years. Super important that we reach out and have an outreach program with our community members to share all the great services and physicians we have working for us here in Humboldt County at Providence. You may ask, why a virtual forum? Well, for the obvious reason, we're still in the middle of the pandemic. Hopefully, we've rounded the corner and we're getting to a little bit more light at the end of the tunnel, but it just is a great opportunity to have multiple presenters in one place from our cardiac care Heart Institute here at Providence St. Joseph Hospital in Eureka, and to give you really an in-depth understanding of the quality services here in Humboldt County. I just want to do a couple of housekeeping things, let everybody know how tonight's going to roll. We are going to have a number of speakers. In fact, we have our Chief Executive, Dr. Roberta Luskin-Hawk, will join us tonight. Also, Joseph Arcidi, who is one of the key members of our physician team at the Heart Institute, alongside Dr. David Phillips, and then Corey Cooper, who has been here for quite some time as a registered nurse in our cardiac program, a registered nurse for 17 some years here in Humboldt County, and just a really pillar of our cardiac care community in Humboldt County. So we're happy to have her as well. Just a couple of things for those of you that want to post questions in the Q&A session. We will have a Q&A session towards the end of tonight's forum. So we'll have the presenters present, and then at the end of the final presentation, we will open it up for questions and answers from the community and from our providers. So there is a little you can see a dialogue icon in the upper right-hand corner of the Teams platform here tonight with a little question mark in there. Post your questions right to there. And as we go through the presenters and their information, if you've got a question that is specific to a presenter, put that this question is for Dr. Phillips or Dr. Arcidi or for Corey, and we'll make sure that our comms lead who's handling the Q&A session, Carly, will note that and ask that question specific to them. So without further ado, let me introduce our Chief Executive here in Humboldt County for Providence. Roberta's been with us now for over 3 years. Having a physician as a chief executive is really a benefit, not only for those of us that work here at the hospital, but for the community to have somebody with a really in-depth understanding of the clinical aspects of running a hospital. Roberta came to us from Chicago. So she followed her daughter out here to college down in the Bay Area. She loves the West Coast. We love her. Ladies and gentlemen, I give you Roberta Luskin-Hawk.
Thank you, Christian. It's really an honor to be here today to share with you and introduce you to three of our local experts, 2 of our local physicians, and one of our longstanding leaders for our Heart Institute. Since being here, we've had an opportunity to work closely with Corey Cooper, our Director of Cardiovascular Services. Corey oversees the Cath lab and many aspects of our heart programs. And then we've had, in the last year, we've had some amazing additions. Dr. David Phillips, who is the Chief of Cardiology for St. Joseph Hospital in Eureka and the head of the Cath lab, is an interventional cardiologist who, after internal medicine training and cardiology training, went on to do interventional cardiology training and has been in practice for a number of years, gaining additional experience and expertise in this important field. For some of you, you may have heard us say that St. Joseph Hospital is a STEMI receiving center. What does that mean? That actually means that we are so committed to heart attack care that we have Dr. Phillips and his team and Corey and her team on call, someone on call 24/7, so that if someone gets chest pain or has a heart attack, they can get to the emergency department, get up to the cath lab, and have that blockage evaluated. And when necessary, when a blockage is found, put in a stent, which is saving muscle and lives. At the same time, sometimes they find that there's more extensive disease that actually needs heart surgery. And we are so honored to have Dr. Joe Arcidi, our medical director of cardiac surgery, who worked with us a little bit from August through December of 2020, and now is full-time up in Humboldt. Dr. Arcidi trained at many of the most prestigious institutions in the country, Johns Hopkins, Emory, spent time at the Cleveland Clinic as a clinical associate, and many other places along the way where he's gotten had great training, and then at the Ohio State University and other places developed additional experience and expertise. Dr. Arcidi comes to us with a passion for excellence in cardiac surgery. He loves the area, committed to our mission, and we're very glad to have him. So you get to actually meet a couple of our clinicians and our very strong administrator this evening. I think it's always wise to think about why is it important that we invest in these type of services for our community. It's because we're in our beautiful remote location, and we need to be able to respond to an emergency, save lives, give people healthcare peace of mind, and improve quality of life. And I think this video on Mr. Wayne Caldwell and his experience in the hands of the St. Joseph Hospital Heart Institute really tells the story better than I could. So Christian, if you'll roll the video, I think our audience will find it interesting.
I'm Wayne Caldwell, been in Humboldt County since 1978, love the county, and I love the community as well. I was on this great property working hard and felt pretty good, but had a little what I thought was indigestion. Very quickly I was in the house, fortunately, and passed out on the rug. Donna was there. She stayed very calm. She got 911 on there. First responders got here. They were already aligned and connected to the hospital. They got me from here to St. Joe's very quickly, and everything was right in that sweet spot of timeline. The cardiologist, once they got in there, I only had about 30% blockage in general, so it never showed up. And a little flap broke off, and it went from 30% to 100%. The thing that still shocks me is the doctor said, well, you had about 10 minutes left. And if we hadn't got you in there, you might not have made it. Fundamentally, they saved my life. Cath lab did a wonderful job. I woke up in the recovery area. It was almost like it had never happened. This local ability to handle something like that is critical. Less and less we're having to leave the area. St. Joe's is an amazing facility for a rural community like ours. The quality of life is hugely impacted by the healthcare we have here. The ability to attract quality employees, to bring new doctors in, and have their families be successful here, we have to have a great hospital. The relationship that a community has with the hospital is critical to the sense of well-being that we have. And so I love giving to the hospital, whether it's the trauma center, heart center, the cancer care. And one of the main reasons is it touches everybody, from the homeless people that are struggling to the wealthiest person in the county. They all come to the same hospital. And so for me to donate and give my time and energy to the hospital, I feel like I'm able to touch more people. I think that the hospital has stood out to the community, and the level of commitment is extraordinary. And I think the community really sees that, maybe more than ever before.
Wayne Caldwell, pretty special guy, received some real special care here a few years ago. It's exciting when you get to meet somebody who has had that type of experience. I know that I met Wayne a few years ago when I was in the foundation. I just got to say the passion he has for our community. We are all very fortunate to have someone who has that type of dedication to support local healthcare. He always talks about how it's important to have a strong sense of peace of mind as it comes to healthcare in rural places, and certainly we appreciate his support, and we appreciate all that our care providers do for us in the program. So now we're going to go right into our presentations. Thanks so much, Roberta, for that intro and some background on the Heart Institute and all the amazing providers we have working for us. Our first presenter tonight is Corey Cooper. As I mentioned, Corey has been a nurse for 21 years. She has been in the Cath lab for 17 years. She's worked in the Cath lab in 9 different states and 13 different hospitals. She truly is amazing. She is again, a pillar in the community. So we are happy to have her not only on our team, but on the Humboldt County team, to have her as a longtime resident in Humboldt County. So Corey, I've got your PowerPoint up and ready to go. Just let me know when you're ready to start talking, and I will start advancing your slides.
Okay, thank you very much. Thank you everyone for joining us this evening. I hope that you are comfortable in your home or your office enjoying a very heart-healthy snack on this beautiful evening. Yes, and that video of Wayne Caldwell, he's a very close family friend of mine, and I happened to be working that day when I got the call of the STEMI overhead, and when I got the name, the feelings inside of my heart just sank. So, and then to see this video this week was very touching to me. But yes, I came here to Humboldt County 10 years ago as a travel nurse, and I have been here ever since. These pictures are kind of, we send out, when you come in as an outpatient, we send out a thank you card after your visit, and over the past decade, we like to update our card frequently with our current staff members. So these are just some pictures and a little walk down memory lane for myself over the last decade here in the cardiac cath lab. So what I'm going to talk to you this evening, we start, as they said, I'm the director of cardiovascular and cardiopulmonary services. So that means that I oversee the non-invasive and invasive procedures that we offer for cardiac and cardiopulmonary at St. Joseph's. So I'm going to start with the most non-invasive testing that we offer. If you go to see your physician and you're having some palpitations or chest pain or not quite sure what's going on, oftentimes they'll start with non-invasive patient testing. So at the top we have stress testing. We offer that 5 days a week, Monday through Friday. We offer 3 different types of stress testing: the traditional treadmill, where you walk on your treadmill, which is the absolute best because it's your true body working your heart muscle and seeing what's going on. We offer a stress echo, which means we are doing the same thing with the treadmill, but at the same time we are using an ultrasound of your heart to see what's going on, where we put you on the treadmill, we exercise you hard, and then when we lay you down, we get really fast images using the ultrasound machine as your heart is working at its peak moment to see what's going on. And then we also have nuclear and pharmacologic stress testing. So with that, we have a brand new camera. It's about 2 years old now. It's a beautiful cardiac camera where you sit up and have your nuclear images taken. So body size isn't as much of an issue. It's very comfortable. We take resting images of your heart, and then we bring you upstairs and we inject a pharmacologic agent with the physician beside you, looking at your EKG, we see what's going on, and then we go down and get more images of your heart. So 3 different types of stress testing. We offer those for outpatients and inpatients. And then next we have echocardiograms, which is echocardiograms, which is an ultrasound of your heart, ultrasound imaging. We got 2 new machines this past year, thanks to the foundation. And they're beautiful new state-of-the-art equipment. They offer strain imaging, which allows us to see the a little bit in depth of the cardiac muscle. And it also offers, we have 2 TEE probes with that, in which if we do a transesophageal echocardiogram where we go down your throat, we'll numb that up, we go down your throat, we take a look, and we have 3D and 4D imaging with that. So if you need a valve replacement, the 3D and the 4D images give our cardiac surgeon just an amazing view of your valve from a different point of view. So they have a very good sense of what's going on and what we're going to do. Lastly, we have the Zio Patch Monitoring. That's super easy. We offer that 6 days a week during the day. The Zio Patch is a new monitor that has no leads. It has just that large sticker that you can see on the chest there in the bottom right. And you can wear that anywhere from 2 days to 14 days. It's a continuous monitoring. And if you're having any symptoms, it is a continuous monitor, but you just press that little button there in the middle and it'll kind of put an asterisk there. So when our cardiologists are reading that, they'll say, oh, you were feeling some symptoms, and yes, something was happening. So they can link those together to come up with a better diagnosis for you. So if those 3 tests might have not gone so well and you need further treatment, then we're going to bring you for more invasive testing and bring you to the cath lab. So the bottom right image is what we call a dual plane, and we have one of those that was brand new when we opened up the Northeast Tower in 2013. And there are 2 cameras on there. The one that's over top of the table is a cardiac camera, in which we look at doing a left heart cath. And then the one that's kind of parked in the back is what we call our vascular camera. We do approximately 600 heart caths a year at St. Joseph's, and about half of those turn into interventions where we actually put a stent in, a PCI, percutaneous coronary intervention. And then with the vascular camera that's parked in the back, we actually do approximately, last year we did almost 1,100 peripheral interventions. So that's any other part of the body outside of your heart muscle. So it can be your legs, your arms, your carotids, and your neck, your renals, so everything else. In the top right, you'll see some images of blockages of your heart. That's the LAD, and then there's a blockage of the right coronary artery, and I do believe Dr. Phillips goes into depth a little more about those during his speech. I do want to say, during the pandemic and times of COVID, since that's what we're here also discussing tonight, we do want to keep you as safe as possible. And if you are scheduled for one of these invasive testings, we do COVID testing prior to your procedure to keep you safe and to keep our staff safe. Next slide. Some of the procedures that we perform in the cath lab, I've already kind of mentioned a little bit, a right and a left heart cath. So a left heart cath is where we're looking at the arteries, the plumbing of the heart. That's where we would look for the blockages. The right heart cath refers to the venous side, and that's where we're looking at the pressures of the heart. We do peripheral and cardiac interventions, cardiac and peripheral stenting. We do pacemaker implants. We did approximately 220 pacemaker implants last year. And we do a lot of cardioversions. So if you come in an abnormal rhythm, atrial fibrillation or atrial flutter being the most common, we will do sedation and shock you back into a normal rhythm. So the bottom left is a picture of the pacemaker implant. The middle picture is a cardioversion where you're in that abnormal rhythm, and then the shock is in the middle to a normal rhythm. And then on the right, you'll see the balloon angioplasty with stenting. And Dr. Phillips, I believe, will talk more about that. Next slide. If we are unable to do the cardiac stenting and you are referred for open heart surgery, you will then get to meet Dr. Arcidi for a possible CV surgery consult. If you have a stent or if you have open heart surgery, the final phase of my area of cardiovascular services is cardiac rehab. Our cardiac rehab is open Monday through Friday, 8 to 4:30 for outpatients. We have a rather small area in which it's been a little bit challenging in the times of COVID because we have to social distance more, so we've had to cut our capacity almost in half. So we are currently looking for a little bit larger space on the St. Joseph campus so that we can expand our services, offer more equipment, spaced out a little bit more for your safety, but we are still offering it Monday through Friday, 8 to 4:30. And that is the last phase of the cardiovascular services. If you go to cardiac rehab, you do get 36 visits. That's the standard post-intervention and post-open heart. And we have nurses and or exercise kinesiologists that will be there to assist you during your cardiac rehab. And then finally, I just want to talk about Stemi designation, because when I came here, this was something that they had been working on for a couple of years and it just didn't get going. So that was one of my exciting things that we got going. And then finally in 2016, we were awarded with our Stemi designation. And this is a picture of Dr. Michaels and Dr. Locke, who were our physicians at that time. So Stemi designation, we are the only hospital with a cath lab in a 4.5-hour driving radius. So it's very important that we have our cath lab in our community and that we're here for you. And what the Stemi designation allows us to do, like Roberta said, we have staff on call 24/7 with our interventional cardiologist and a CV surgeon. And what Stemi designation really allows us to do, so when you have chest pain, you're going to call 911. We encourage you to call 911 and not drive yourself to the hospital, because a lot of things can happen in that short amount of minutes that it can take you to get to the hospital. Plus, when you come by ambulance, you're just triaged differently, and you'll come right into the emergency room differently with chest pain. So by law, if you call an ambulance, they have to take you to the nearest facility. Being STEMI designated allows them, because our closest facilities being Redwood or Mad River, if you're in that area, they don't have cardiac care. And when you're having a heart attack, time is muscle. And by law, if they have to stop at those hospitals, then your heart muscle is dying, and we need to get you to our facility as fast as we can. So STEMI designation allows North Coast EMS and the ambulance services to bypass those facilities and get you to St. Joseph's Hospital as fast as possible so that we can take care of your heart. So that's what STEMI designation means and why it's so important. With that, we have monthly meetings. We have quarterly meetings where we look at every single STEMI and non-STEMI that comes into the hospital. And we look at every single minute from the time that the STEMI is called to the time that you get to the cath lab and we open up the vessel. Looking for all of our opportunities to improve if we can, and where we did well. And we do a very nice closed loop communication with our EMS system and other referring hospitals if they do originate there. So that's really all I have to talk to you tonight. Thank you for being here. If you have any questions, please put them in the chat. Thank you.
Awesome. Thanks, Corey. Appreciate all that useful information for our community. Yeah, just that designation for STEMI has been huge. We hear great stories daily here in the hospital where that designation has saved lives, and couldn't be more proud of having that service here in Humboldt County. What I'd like to do now is to go ahead and introduce our next presenter, our first physician presenter. Excuse me, that is Dr. David Phillips. Dr. Phillips has been here, just joined within the last 12 months, if I'm not mistaken. And he has been an excellent physician for us to add to the team. And as I call up and look at his slide right here, I want to make sure that I've got the right one. This is the beauty of live virtual forums, is that we are on making sure that we've got everything queued up and ready to go. And Dr. Phillips, now I have your presentation ready to go. You can unmute yourself and go.
Well, thank you, Mr. Hill. Good evening, everybody. Thank you for allowing me to speak. Yes, in case you're wondering, that was me in the picture wearing the Zio patch during Ms. Cooper's presentation. Thought I would throw that out there. I'm going to speak about coronary artery disease, which is part of the focus of this evening's presentation. If you could advance to the next slide. So what is coronary artery disease? It's actually an inflammatory condition that is stems from years worth of stress and insult and damage to the coronary arteries. These pictures here, top left corner shows an example on the left of what a normal looking artery with 3 nice layers in it should look like. With insult and injury to that artery over the years, what happens is you get inflammation within the walls of the arteries. You get white blood cells that move into that space, and with that you start to deposit cholesterol or fat within the vessel. In that top right picture, an example of what a clean artery should look like on top, with a wide open what we call lumen, which is the inside of the artery where blood flows. When you add plaque inside that wall, in that lower picture on the top right, you can see that starts to grow in and obstruct the flow through the center of the vessel. Next slide. So what are those insult and risk factors, and what causes that damage to vessels? So there are multiple risks. Some of the top ones include diabetes mellitus, which is high blood sugar levels. Cigarette smoking is a major risk factor for damage to the vessels. High blood pressure, which we define as an average blood pressure over 140/90 at rest. That causes shear stress and damage to the wall, leading to more plaque buildup. high cholesterol levels to begin with, particularly the LDL and triglyceride levels, which can be checked on lab tests. Along those lines, an unhealthy diet, so red meats, processed foods, foods high in saturated and trans fats, for example, and then lack of regular physical activity. The American Heart Association recommends that we all take a 30-minute walk or something equivalent to that, like a bike ride, at least 5 days per week. And if we're not doing that, we're not doing enough. So those are things that we have a lot of control over, at least to some degree. Some of the things we have no say in are aging. So being a male over 45 years of age is a risk factor for progressive atherosclerosis. Over 55 for females, and then a family history. Genetics is obviously very important, particularly if your father or the males developed coronary disease or had heart attacks at an age less than 55. For females, heart attacks less than 65 years old is a risk factor. Next slide. So what are the symptoms? One of the key points I want to make is that not all people have the same symptoms with their heart disease. You may have coronary disease, your neighbor may have coronary disease, and your symptoms may be completely different. Sometimes it's just one recurring symptom that occurs, sometimes there are multiple symptoms. We refer to a person's symptoms from the heart as angina or angina. Typically with stable angina, these occur with exertion, so taking walks, doing yard work or gardening, something where you're getting your heart rate up. That is typically when symptoms present. They can be chest pressure, described as a pressure or a heaviness, a tightness, a squeezing. Can be described as somebody standing on a person's chest. Sometimes people describe it as heartburn, like. That chest discomfort can radiate into different areas. That includes the arms, typically the left arm, but it can also go to the right. It can radiate up into a person's shoulders, their neck, their jaw, even up in their upper back between their shoulder blades typically. Some people have discomfort more in their epigastric area, which means their stomach area right under the breastbone. But also important to know is that up to a third of people do not have any kind of chest discomfort whatsoever. This is more common in females, as well as people who have had diabetes for a long time, years. They may present with instead progressive and significant shortness of breath with activity, finding that they have to stop frequently to catch their breath before they can continue on with whatever they're doing. Sometimes people can just have arm discomfort, just neck discomfort, just jaw discomfort without any discomfort in the chest. Some people, it's even more subtle than that. They just start to feel more fatigued, find that they just can't keep up with the things they normally do, just feeling wiped out. And those symptoms tend to get worse and worse over time. So what about a heart attack? An acute heart attack can be any of those same symptoms I just discussed, but they tend to be very intense when a heart attack occurs. You're not getting any blood flow to the heart muscle. Your symptoms are usually not at all subtle. It can start out. You can start out with your symptoms, let's say, for example, chest pressure at home. It may last for several minutes or an hour, then go away, and then come back several hours later. You can have sort of a stuttering come and go type of pattern. Eventually, it hits a person and doesn't go away, and it's pretty obvious something's wrong. These symptoms can happen anytime with an acute heart attack, particularly at rest, sitting down, lying down. It's not exertionally related. Often with a heart attack, because it's a significant event, there are other symptoms. You may or may not start sweating profusely, may feel sick to your stomach, may even throw up, may feel lightheaded or faint, feel extremely weak. Others around you may tell you that you look pale and sweaty. That can all be a sign of a heart attack. Next slide. So it's been found that people typically will wait anywhere from an hour and a half to 2 hours once their symptoms start and persist before they even go seek any medical care. And why is that? So we hear different things all the time. These are some examples. People may feel that their chest discomfort isn't what they heard it should be on TV. I didn't have an elephant on my chest, or my chest discomfort didn't go into my arm, so they don't think it's the real deal. Some don't feel, whatever it is, that it's very serious, and maybe a form of denial, if you will, and feel like it'll probably go away with time if they just let it ride out. Some will say it's probably just my reflux, and this is in people who have had chronic reflux from their stomach and in their esophagus for years, and even when the heart attack symptoms feel different, they'll still sort of say, well, it's probably just a version of that reflux. So there's a lot of downplaying that can be involved. Some people feel that they would be embarrassed if they called 911 or went to the hospital and it turned out not to be their heart, and that's understandable, but better to be safe than sorry. We've had people wake up in the middle of the night with their symptoms. They're lying next to their partner or spouse, and they just don't want to wake them up and inconvenience them, so they don't. Some just don't feel like they fit the typical profile, where they're not an old man, and why would it be my heart? It shouldn't be my heart. And then some, another, I guess, form of denial is, well, we'll just call our doctor tomorrow. What difference does it make tonight? I'll write it out. Next slide. There was, in 2011, an observational study that looked at 38,000 patients, and with that data, they determined that people who end up in the hospital with heart attacks, about 60% of those come in on an ambulance after calling 911, which means that 40% of people end up driving in on their own, having somebody drive them in. But as Ms. Cooper mentioned before, it's highly recommended that you call 911, that you get an ambulance to bring you in. And why is that? Studies have shown that about 1 in 300 people transported to the emergency room in their own vehicle, either driving themselves or having someone drive them in, will actually have a cardiac arrest while they're driving in, meaning essentially that they die on the drive in. And oftentimes they cannot be resuscitated once they get to the hospital. Sometimes they are resuscitated by emergency room staff, but that's after 5 to 10 minutes of having no blood flow to their brain, and they're never the same person if they do survive. Another important reason to get the ride in by the ambulance is that you are taken care of by professionally trained EMT, basically professionals who will prepare you on the way in. They put in IVs, they start treating you medically, they can help stabilize. If you do have an arrest on the way in, they will save your life. In addition, they're able to gather data and send that into the emergency room and to the cardiology team ahead of time to notify them that you are on your way in and you're likely having a heart attack. That has been shown to save significant amount of time in getting you to that cath lab and to get that artery open, to save heart muscle, and to increase your chances of surviving the whole heart attack. So if you develop symptoms, you think you may be having a heart attack, the recommendation is chew on 4 aspirin. If it's a 325 milligram aspirin, chew on one of those and call 911 and come in. Next slide, please. So what happens during a heart attack itself? That diagram with the arrows on the right there, you can have plaque in those walls, and what happens is something causes a rupture in one of those areas, usually in the corner, as that diagram shows. When a plaque ruptures in an artery, the platelets and things circulating in your blood will stick to it, and it forms a blood clot. And once that blood clot forms in that artery, it shuts off all blood flow to that part of your heart muscle. Next slide. I won't get into too much detail on this, but the importance of this is that heart cells will start to die immediately. Once that artery shuts down, you are killing off heart muscle. And what that diagram shows is that most of that damage occurs in the first 3 hours of your symptom onset. Once you start to reach the 6 to 12 hour mark and you haven't done anything about it, most of the heart damage has already occurred and you're not going to save much at that point. It's still important to come in, but you've missed an important opportunity and window. And as the recurring theme, time is muscle. Next slide. This is an example or diagram of what is happening exactly in the top left. The arteries right on the top of the heart muscle, then they extend these small branches down into the meat, the muscle itself of the heart. The top right diagram, that purple dot there is supposed to represent the artery, which has just suddenly shut down its blood flow from the blood clot forming in it. That tan area and that circle underneath represents all the muscle that artery is feeding and supplying. And what that shows is over time, The next one over on the right, 20 minutes out after the artery is shut down, that dark area is supposed to reflect permanent damage to the heart muscle. And the longer you wait, the more that permanent damage starts to spread out and extend to the end of the wall, so that by anywhere from 2 to 12-hour time period, that whole area has been infarcted off and it's all dead and you're never getting that back. The fancy pictures below MRI and some gross specimens, that white area on both of those pictures is actually a real heart attack. That heart muscle you'll never get back. Next slide. For the sake of time, I'm going to skip this one and skip this one as well, please. Okay, so you get to the hospital and we get you to the cath lab, as Ms. Cooper discussed. This is a live picture of our team in the cath lab. Next slide. So what do we do when you get there? What is a heart catheterization? So we access the radial artery or the femoral artery to get to the heart. That's what the top left picture is demonstrating, a catheter going through the wrist. The picture in the middle, those are examples of catheters that we use. They're just long, hollow plastic tubes that ride up the artery to the heart. That top right picture, that blue catheter is sitting in the aorta with the end of it going into the left artery. We can push iodine contrast through that into the vessel. That's how we see what's going on. We can then thread a wire, which is what's drawn there. That wire gets advanced across the narrowing, the part of the artery that's causing the damage or the problem. And then the bottom right picture is an example of a balloon that slides over that wire so that we can get that balloon to the exact spot that we want to fix. We inflate that balloon from the outside and open that vessel. Next picture. So how again do we access, how do we get in there? The radial artery or the femoral artery. So the top left is an example of the radial artery access. I do over 80% of my cases through this access. The reason for that is patients tend to prefer that over the leg. It tends to be more comfortable, easier recovery afterwards. You can have bruising in that area, but you can't really bleed to death from your wrist because we can see it and hold pressure and stop it. Studies have actually shown that when you're having a heart attack, if we access the wrist, the long-term outcomes are better, including mortality, meaning less death overall in the long run. It also helps us get you out of the hospital more quickly. And another advantage is people who have vascular disease, cholesterol buildup in arteries in their legs and aorta. We don't have to get through that to get to your heart. The bottom right picture is the femoral artery. That's an X-ray picture that shows the head of the femur and the pelvis. You can see, well, maybe you can see that, it doesn't really point it out, but the sheath that we put into the artery, we push contrast in it. That's how we see that femoral artery, and that's how we get to the heart. The reason we would use the femoral artery, sometimes the artery in the wrist is too small. That particularly is common in older females who are very thin and small arteries. Sometimes we'll have to use the leg. If you've had a prior open heart surgery, sometimes we have to use the leg because we need that leg access to get to all the grafts. We can't get to all of them from the wrist. And sometimes if you have a more complicated procedure requiring a lot of equipment, it gives us bigger equipment and makes the procedure easier. So sometimes we'll switch to the leg for that reason. Next slide, please. So what is a stent? This is an example of one of the stents that we put in arteries. It's basically made of metal, typically cobalt chromium or some kind of alloy of cobalt, platinum-based alloy. It's covered usually with something that is biocompatible, meaning that the body will not see it as foreign, made up of things that you would have in your body anyways. That helps reduce inflammation. And often these fancy stents we use have a coating over them which emits a drug which helps reduce scarring from the stent. Next slide. More pictures, different types of stents that we use. There are different types of stents, drug-eluting, as I mentioned, versus the bare metal. The bare metal stent does not have that fancy drug to reduce scarring. So why would you use one over the other? We typically will use the drug-eluting stents because it reduces scarring formation inside the artery. With the fancy drug-eluting stents, about 5% of people can have significant scarring inside that stent to the point that that starts to slowly over time reduce flow through the artery, which could mean that we need to put in a second procedure and another stent in that same spot. With the bare metal stents, without that drug-eluting, that scar formation can be significant in up to a fourth of all people. So we prefer the drug-eluting stents. No difference in mortality. You're going to live just as long whether you use the bare metal or the drug-eluting, but less reason to come back for more procedures if we use the drug-eluting stent. Why would we use the bare metal at all? It has to do with the blood thinners that you're supposed to be on afterwards. With the bare metal stent, you don't have to be on those as long. So if you have an upcoming hip or knee surgery and you need to stop those blood thinners for that procedure, we might use a bare metal stent to allow you to get off the medication sooner. Next slide. This is a diagram again just of the stent placement. So the top one on the right is the stent, which is wrapped around a balloon over that wire. In part B there, we inflate that balloon from the outside. It opens up that stent, stretches it out, pins that against the wall. You're basically pinning all that plaque into the wall. We don't remove it. It doesn't go anywhere. It just gets stuck behind that stent. But in the bottom slide, or on the slide on the left, I should say, bottom left, that's an example of what the effect is afterwards. It's opened up that inner lumen, meaning the inside of the artery where blood flows, and improves that blood flow there. And the bottom one, C, there is after the wire and the balloon come out and the metal stent stays in your artery, and it's there the rest of your life. Next slide. So after the heart attack, you get a stent, you spend the night or two in the hospital, then what? That top picture is kind of a joke, but it's partly true. You're going to be on a lot of pills that you may not have been on before, and that's based on years worth of scientific and medical literature and data indicating benefits of certain medications. So that includes an 81 aspirin the rest of your life. It includes something like aspirin, and I wrote up examples there, Plavix, Brilinta, you may have seen commercials. You'll usually be on that for about 12 months after a heart attack, at least 6 months for drug-eluting stents. Statin therapy is probably the best pharmaceutical medication, best medication we have on the market to slow down further cholesterol buildup in arteries and reduce risk of heart attack. And I'm sure you've all seen those on commercials at one time or another, Lipitor, Zocor. Blood pressure control is very important. As I mentioned earlier, a normal resting blood pressure should be less than 130/80. Possible medications you might get to help that happen are what we call beta blockers, such as metoprolol, ACE inhibitors such as lisinopril, different types of medications which have other benefits after a heart attack as well at reducing heart failure, improving heart function, and keeping you out of the hospital. If you're a smoker, you absolutely need to stop smoking no matter what we do for you, no matter what pills we give you, no matter how much exercise you get. If you keep smoking, that plaque in those arteries is going to continue to accelerate, and we will see you again. We will be putting in more stents if you survive the next heart attack at all. Diabetes control is important. We like that A1C less than 7, and you know what that is if you have diabetes. Regular exercise is recommended, as Ms. Cooper talked about. We do have a cardiac rehab program that we'll send you to after a heart attack. And then a heart-healthy diet, which they can also help guide you on. Mediterranean being a typical heart-healthy diet that we recommend. Next slide. I'm going to skip this. I was just going to talk about the Impella device. It's just basically some fancy support devices that we have for people who are in heart cardiogenic shock, we call that. They're in shock and things are not looking good. We can put this into the heart, and it assists the heart to get you through the procedure and help you survive. It's temporary. Next slide, please. Go next. I'm just going to show you a few live pictures so you kind of have an idea, and then I know I'm probably going over time and we'll move along here. But these are examples of your coronary arteries. These are healthy arteries. The walls are essentially pretty smooth. Left anterior descending artery going down the front there. So we look at it from different angles to really get a good look at all the arteries, both on the left and the right. Next slide. So this is an example I want to show you. This was an 80-year-old female who came in with a sudden heart attack, and the left circumflex artery, which is that artery right in the front there, had shut down, and that supplies the side wall of the left ventricle, pumping blood out into the body. That top left line is the catheter that we put in. That dark stuff is the contrast. Some of that spills out on the left, but most of it goes in the vessels. That's how we see what we're doing. So if you focus on that dark line that goes down the center, it just suddenly stops in the middle, and there's nothing after that. And I'm sorry I can't point to it specifically, but you'll see on the next picture. So the top left still frame is the catheter with the wire in the artery. That dark line there is the balloon that we're inflating that has the stent wrapped around it. In this particular case, it was a 2.25 by 28 millimeters ion stent. These are small vessels. And then the picture on the right shows now what that artery that was shut down really looks like. It no longer stops right in the middle there. It extends on down to the side of the heart there. Next slide, I'll show you one more here, and then I'll wrap this up. So this is what the EMT would see and what the emergency room staff would see if they did an EKG when you're having a heart attack. This again is the reason to call 911 so they can send this in before you even show up. This was a 66-year-old male. In this particular case, he had had a prior bypass surgery about 20 years previously, and he was having a heart attack on the bottom part of his heart. That's the picture on the right with that line on the top right. That's our catheter. We push contrast through that. You're not really seeing much happening there, and that's because that whole vein graft has been shut down. Those dark lines on the top left, those are sternal wires, which my colleague Dr. Arsidi could talk about. That's an evidence that you've had bypass surgery in the past. Next slide. And that's, again, still frame on the left side of the wire in the graft and the balloon stent going in, and then the end result on the right side. You can see how different that picture looks. Huge vein graft has now been opened, and you're getting blood flow to the arteries underneath the bottom of the heart on the bottom right there, and everybody's happy. I think I will end there for the sake of time. It's more of the same. Thank you for giving me the opportunity to talk, and I'll talk to you soon in the Q&A session.
Christian, you're muted.
I double-clicked, my apologies. So I was just telling everybody, the attendees, if you have questions, please put them into the Q&A session up there on the right-hand side, the dialogue bubble with the question in it. That is for you to put your questions in. So I'm going to again introduce Dr. Joseph Arsidi. Let me get his PowerPoint ready to bring up on the screen, and then I will make sure that we send him live as well into our discussion. So Dr. Arsidi, if you want, go ahead, open up your microphone, and you can start talking to us about your presentation.
Thank you very much, Christian, and I'm really honored to join what is just a superb team. We really have phenomenal folks and practice great medicine, and the two previous speakers really portrayed that very well. The message is really almost in this very first slide. For people who know that cardiac surgery is a re-energized service here that we're providing at St. Joseph, I want to emphasize that we're here to serve you, our community, by providing what's really state-of-the-art care. Next slide. Very simply, I want to, in this sort of animation type slide, give you just a brief introduction to the sort of procedures that we provide here very frequently at St. Joseph Hospital. Next. The first of these is going to be coronary artery bypass grafting, and this animation shows two different types of bypass grafts. Now, Dr. Phillips is opening up the narrowings or blockages in these arteries. Coronary bypass grafting takes a different route. It constructs detours to get around these blockages, and those detours historically were most prominently a vein from the leg that you see on the right side of the screen, and that's attached from the aorta beyond a blockage right directly sewn onto the artery. And on the other panel there, you see a bypass graft that's constructed in this instance from an artery from the inside of the chest wall, called the left internal mammary artery in this instance. And alternatively, we'll use an artery from the other side of the chest wall, or very commonly an artery from one of the two forearm arteries. And our own national organization that has the abbreviation STS has really strongly been encouraging cardiac surgeons to perform more bypasses with arteries, and because they have a longer durability, even though they're more meticulous to perform. Next slide. The next common operation we do would be heart valve repair or replacement. And historically, this shows the aortic valve. You see in that oval circle, the aortic valve is a bit hidden in the way this cut. These are operations done on the inside of the heart where the valves live. And the aortic valve is one that we generally would replace. We're using more tissue valves to replace valves rather than mechanical valves that require long-term blood thinning. Next. These other two valves are ones that we also operate on. The tricuspid valve is on the right side of the heart, and the mitral valve is on the left side. And what's common about both of these valves is that they look somewhat similar, but also that repair rather than replacement of these valves is certainly the more desired procedure. Next. Atrial fibrillation is a very common heart rhythm that most folks know. You can see a bit of an EKG that might show it, and that is where the top two small pumping chambers that are kind of flashing here, they have these circuits that form, and these chambers will wiggle rather than have a defined beat to them, and patients can be quite symptomatic from it. In good risk patients, there's an operation that can be done commonly in association with a valve operation to correct the surgery, and it goes under a title of the Mays procedure. Next. Back to, those are three commonly performed procedures, but one of the things that we're excited about, Dr. Phillips showed the Impella type device. We're also hoping to introduce to our region, being the only heart center in the area, a way to support patients temporarily who really can't survive without what we would call mechanical or pump support. And the type of device that we're hoping to be able to apply to patients goes under the abbreviation ECMO or ECMO, that will support both the heart and the lungs. Next. So I've been coming here since the late fall, and we've had some early achievements already that I wanted to share with you. Next. One of the things that we're excited about is that our patients are receiving fewer blood transfusions at St. Joseph Eureka than if you look at the frequency in the entire database, that STS database that looks at all the heart programs in the country and frankly in North America at least. Next. I emphasized how the long-term durability of constructing bypass grafts from arteries rather than from veins is to the benefit of patients. And I'm proud that our team, again, this is always a teamwork effort, we are certainly outperforming nationally the frequency where patients are getting more than one artery in the course of their bypass operation. Next. This is something that we're quite excited about. Only a few centers with very advanced teams are able to have patients stable enough that we can more often take out the breathing tube that they've been using in the operating room, actually in the operating room, rather than 6 or 8 hours afterwards, or even longer than that. And we're far exceeding the national frequency of that. And that's really been a real benefit to not only the patients, it also makes them more stable for the nursing staff. They're able to talk to their families earlier, and it really has been something that we're quite pleased to already see happening. Next. One other trend that I would share with you, it's early so far. I did mention that the aortic valve was the valve that is more frequently operated on compared to the mitral heart valve. And overall, the average cardiac surgeon in our country generally sees 5 mitral valve cases on average in a year and would only be repairing about half of those patients, certainly something that the STS organization has been concerned about. Well, already we've performed 4 mitral valve operations just since October and have repaired all of them, and some of them have very complex pathologies. So we're pleased that our team has been able to provide that. And finally, among our goals has really then been providing state-of-the-art cardiac surgical care here close to you at home. And certainly all of you know the beginnings of our hospital and our healthcare organization. Certainly we'd hope that while our nuns may not have been able to see these developments, but they'd be pleased that we're providing compassionate care and preserving the legacy that they brought to our region. Thank you very much.
Thank you, Dr. Arcidi. Appreciate that presentation. So that brings us to the end of our presenters with their presentations. We're going to move into the Q&A section. Right now I see we've got plenty of attendees, so if you've been saving a question to post to the Q&A part, go ahead and post them now. We've got a few in the session, or in the section right now for the Q&A. So I'm going to introduce one of my comms colleagues in Northern California, Carly Perkins, who's going to moderate the Q&A session here. So Carly, I'm going to put you on screen and go ahead and read some of the questions for our panelists tonight. Thanks so much.
Thanks, Christian. Hello, everyone. So the first question comes from Paul, and Paul asks, please explain the difference between CHF and a heart attack. Are they treated differently?
I can take that one. So a heart attack, as we discussed, is when you basically cut off blood flow to the heart muscle, so you get heart muscle damage. It's a blood flow issue. Congestive heart failure is more of a condition, and it's actually more of a clinical term that we use. The heart is a pump. Its job is to circulate blood throughout the body, and anything that diminishes the ability of the heart to do its job to circulate blood can cause congestive heart failure, and that can be decrease in heart function, and that can occur with a heart attack when you damage heart muscle. Your heart squeeze, the pump doesn't work as effectively, you don't circulate blood as well, and what happens is pressures build up in the heart, behind the heart, and the blood that's circulating, because of those increased pressures, can start to spill out into your tissues, and that includes into your lung space, making you short of breath. It can spill out into your belly, your abdomen, causing distension. It can start to spill out in your legs with gravity, and you can start to develop swelling. Once we start to see those signs, that is congestive heart failure. Heart attacks aren't the only cause of congestive heart failure. There are multiple other reasons for a heart to tire out, including heart valve problems, which Dr. Arcidi can fix as well. Sometimes people have normal pumping function and the heart's just very stiff, meaning it won't fill up very efficiently. And that can be just from years worth of really high blood pressures that haven't been well controlled. That makes the heart stiff and thick, and it starts to cause the same pressure problems, and you can develop congestive heart failure. So one can lead to the other, but they're definitely different. Absolutely.
Great, thank you for that thorough response. Another question is, can the effects of an enlarged heart be reversed, and what can cause an enlarged heart?
We have any takers? Dr. Arcidi, would you like to do that? Or Dr. Phillips, you want to have an encore? And Dr. Arcidi, I think I see you talking. You want to unmute and we'll put you on
I think
camera.
Dr. Phillips is probably the best one to answer that one.
Okay.
Yeah,
Great.
sure. And that can be even an extension of what we've talked about. An enlarged heart usually is a long-term sign or effect of heart problems, and that can be the same thing: damage to the heart over the years from heart attacks, from poor blood flow, from too much strain, from untreated blood pressure or valve disease. When the heart is strained like that, it does its best to compensate for those insults, and that works for a while. But over years, if you don't do anything about it, the heart starts to tire out. And when those increased pressures in the heart progress, as I mentioned, that can start to stretch out the heart so that the heart chambers themselves become enlarged. And we can see that on different types of studies, including chest x-rays, the echocardiograms that we perform, and whatnot. Can that be reversed? It depends on the cause sometimes. That's the importance of the discussion on heart attacks. That's permanent damage. You can't fix that. And sometimes that can't be reversed. Some types of valve abnormalities like aortic stenosis, which is a common one, if you fix that, if Dr. Arcidi fixes that valve, gives you a new valve, then the heart can recover from that strain. It starts to improve. It doesn't have to work as hard, and that can improve. Some valve issues like leaking of a mitral valve, what we call mitral regurgitation, if you let that one go too long, the heart dilates, you usually don't recover well. So we are definitely more focused on some conditions rather than others. But so the answer to that question is, yeah, sometimes you can reverse it, but not always. And enlarged hearts are generally not good. It can be the end result of a problem. Sometimes, by the way, it can be temporary because of a viral infection that causes severe dysfunction in the heart and dilation. Often people on the right medications will get through that viral infection, and that can improve. Sometimes that does not improve either. So a lot of different reasons for that, and it depends on the cause.
Okay, thank you. So the next question pertains to COVID. What damage to the heart has been documented due to COVID? This person has heard that it causes hardening, and has there been long-term damage that has been found?
So I'll just speak to what I know about that. Dr. Luskin-Hawk may actually have more information on COVID than I could provide, but from a heart standpoint, some of what we're seeing, people can develop sort of that viral infection that I mentioned can happen with COVID infection as well. And in a percentage of patients can develop a myocarditis, sort of an inflammation of the heart, and that can lead to heart dysfunction and heart enlargement and even increased risk of mortality. The COVID virus has also been associated with the increased risk of clotting, and so that potentially can increase your risk of sudden heart attacks and strokes and whatnot. But I'll turn it over to my colleague for further discussion.
Yeah, and David, I have a lot of interest in COVID, although I always like to clarify, not licensed to practice in California, so it's administrative interest with the infectious disease background. But I agree with you that a lot of what we've seen in heart attacks and COVID were related to the excess clotting we've seen with some of the excessive immune activation and clotting disorders later in the course of disease, and some increased risk of progression of COVID in patients with high blood pressure or hypertension. It's a good time to plug the COVID vaccine. We're seeing some really important reduction in cases in the presence of vaccine, even in the elderly. So hopefully, we've been fortunate that we've been able to really run 2 courses of treatment. We can address those patients in our county with COVID as needed, at the same time have this amazing team treating serious heart disease. And so across the country, there were problems early on in COVID, where people stayed home with chest pain and complications of coronary artery disease, and so, sometimes at risk of dying at home. We were able to create an environment where we could care for our heart patients at the same time, very safely. At the same time, we could take care of COVID patients when when there were higher numbers in the community. So a lot of this great team is there for those people with heart disease, and it's important to address those issues.
Great, thank you. So our last question comes from James for Dr. Arcidi, and they would like to know roughly how many surgeries of the ones that you discussed are performed at St. Joe's Eureka each year?
Well, we're a growing program, and we're hoping to probably perform beginning at 100 cases a year. That I think would be our projection for this coming year. I think the COVID certainly has impacted things, not only in our program, but in programs around the country. So we hope that with cases lightening, that more patients will seek earlier care. I think all of us have seen patients who were fearful not only of their heart condition, but also fearful because of COVID, and delayed care beyond what we would, so that they're not getting early treatment, they're getting treatment for advanced stage problems. And we think that's very unfortunate.
Yeah, and I want to underscore that while, over the last year before Dr. Arcidi came, we certainly weren't doing as many cases. We've got a very capable team in the Cath lab and in the ICU, and have now physicians who, outside of Humboldt County, developed, have huge experience doing this kind of work, and that these early outcomes demonstrated by Dr. Arcidi really shows some world-class care close to home. We know from looking at a lot of data that many patients at one point would leave Humboldt County if they needed heart surgery, which has only gotten more complicated as their, visiting has changed and COVID restrictions has changed the world. So we're very grateful that we can offer in an emergency that trip to the Cath lab and a decision about whether you need an intervention or surgery, but also for those more elective, where something seems to be progressing, whether it's valve disease or coronary artery disease, we can now offer really world-class care close to home.
Roberta, thank you so much for rounding out the answers to our questions. Thanks so much to all the attendees for posting those questions. And thanks to all of our panelists and speakers tonight who took an evening out of their week to share really important information for our community. What I would like to just finish on by saying is that we will continue to have community health forums. As I mentioned early on, pre-COVID, we were hosting health forums about once a quarter. Our plan is to continue to do that, and I think we have an opportunity, maybe even to do more, because we have had a great deal of interest on our growing service lines here at Providence St. Joseph Hospital in Eureka and Providence Redwood Memorial Hospital down in Fortuna. So please look for messaging and information on our website, both at the Redwood Memorial website and St. Joseph Hospital and Eureka website. Additionally, on our Facebook page for St. Joseph Humboldt. We are moving over and getting the new Providence branding for our Facebook page here in the near future, but you can still find us the old-fashioned way via the existing handle for Facebook. So with that, thanks again so much for everybody, or to everybody, for taking time out of your night tonight and joining us for the Community Health Forum on cardiac care from the Providence Heart Institute at St. Joseph Hospital in Eureka. Until next time, have a good night.
Thank you all.